Morning, Dr. Levine. My colleagues and I are here to discuss a serious public health concern in our state and the country at large: burnout among physicians and its effects on patient safety. Together, the four of us were asked to come up with an answer to the problem, which is what policies can the PA Department of Health introduce to prevent burnout among physicians to reduce medical errors in our state? We have a solution, but first we want to provide some background on why we believe that this issue should be a priority for your staff moving forward. So, burnout is a major issue among physicians. Burnout has been defined as a long term, unresolvable job stress that leads to exhaustion and feeling overwhelmed, cynical, detached from the job, and lacking of a sense of personal accomplishment. In fact, a 2018 study from the Stanford University School of Medicine found that physician burnout is at least equally responsible for medical errors as unsafe medical practice conditions, if not more so. This is an important link to note as medical errors are the third leading cause of death in the United States after heart disease and cancer. The Institute of Medicine Committee on Data Standards for Patient Safety defines medical error as the failure of a planned action to be completed as intended, or the use of a wrong plan to achieve an aim. It also includes failure of an unplanned action that should have been completed. The Pennsylvania Patient Safety Authority notified that the total reports of medical errors have risen over the last decade. Pennsylvania based acute care facilities reported 23,222 incidents and 674 serious events, which are events, occurrences, or situations that result in death or compromise patient safety and results in an unanticipated injury that necessitates additional healthcare services. Most common were errors in judgment, wrong diagnosis, or technical mistakes, although 55.4% had no perceived effects on patient outcomes. 5.3% of medical errors resulted in significant permanent morbidity, and 4.5% in patient death, a study reported. Physician burnout can contribute to failure in interpersonal relationships, reduced patient satisfaction, the quality of care, and patient outcomes, as well as increased risk of malpractice and increased medical errors. So, physician burnout can contribute to the failure of interpersonal relationships, reduced patient satisfaction, the quality of care, and the patient outcomes, as well as increased risk of malpractice. What are the causes of physician burnout? Many factors can cause burnout, but by far, 60% of the respondents highlighted that massive administrative tasks or too many bureaucratic tasks, such as charting and paperwork, as the leading cause of burnout. Spending too many hours at work was also a leading cause of burnout, with a 48% of physicians working 51 to 60 hours each week. The Pennsylvania Medical Society identified increased bureaucratic tasks and regulations, time constraints, restrictive contracts, and the endless battle with health insurers on behalf of physicians' patients are the causative factors of physician burnout. Many physicians have reported at least one major medical error, and the risk is said to be more than twice higher among physicians with burnout. The study also identified low safety grades in work units as a risk factors for medical errors, with a much higher rate in medical work units if physicians working on that unit had high levels of burnout. This suggests that burnout could be a bigger cause of medical error than a poor safety environment. So, what is the impact of physician burnout? Well, the impact of physician burnout is quite high, affecting 83% of hospitals, hampering patient provider communication and a positive patient experience. It also affects physicians' productivity and increases the risk of quitting the practice. Physician burnout has huge economic impact on healthcare system by increasing costs, contributing to organizational direct costs of recruitment and replacement when physicians leave or reduce their clinical work hours. For an organization, the cost of physician burnout can range from $500,000 to more than $1 million per doctor.
This slide and the next one presents the legislative history of the issues on physician burnout. Enacting interventional policies to address physician burnout at the state level is not an easy process. Although the Pennsylvania Act 13 of 2002, the Medical Care Availability and Reduction of Error Act, established the Patient Safety Authority, there is no specific legislation or policy on physician burnout in the state. However, there are state-based organizations that have engaged in advocacy roles and on physician burnout. For instance, the Pennsylvania Medical Society, PAMED, has a foundation that administers the Physicians Health Program that provides mental health services to doctors within the state. Also, generally, hospitals and healthcare systems in Pennsylvania have developed new programs and initiatives aimed at mitigating physician burnout and eliminating medical errors. Medical schools have also been playing roles in this area, trying to prevent burnout among student physicians and young physicians. Looking at the process, the structure of decision-making in the government. The Pennsylvania state government decision-making process is a very complex one that involves committees, sessions, caucuses, subcommittees, bill versions, procedures and issues in the House of Representatives and also in the Senate. The House of Representatives has a total of 203 members, and the Senate has 50 members, and all these members are involved in committees to make decisions about bills. In the Senate, there are 22 committees, and in the House of Representatives, there are 28 committees, all working in different areas and on different policy issues. The House Standing Committee plays a very pivotal role in the process of making bills or policies, including holding public hearings anywhere in Pennsylvania to get public opinion and input from stakeholders. For this very program, there are committees that we consider relevant to the issue of physician burnout. The Health and Human Services Committee, the Labor and Industry Committee, and Appropriation Committees are all very likely to be involved in the issue of physician work environment and the burnout issue. However, the primary target committee for this health policy paper will be the Health and Human Services Committee. Once a bill has passed through the rigorous process of debate, discussion, and approval in the two houses of Representatives and the Senate, and then is signed into law by the governor, the real work on translating the bill into action begins. The question that will be addressed in this slide is which agencies will be involved in setting the regulations, rules for this policy to translate it into action. The Pennsylvania Department of Health will be the primary agency to set regulations and rules dealing with physician burnout and healthcare quality, and also dealing with the work environment issues, rules, setting rules and setting up programs that will improve physician burnout and improve healthcare quality. Primarily, because it is responsible for improving healthcare quality, access to healthcare, continuity and accountability issues in the healthcare system. Therefore, it is assumed that it will be the primary agency. However, other departments like the Department of Human Services can also play a role in the program administration. Besides these agencies, professional associations, for example, American Medical Association, will also be an important role player in this issue. Partly because it is a very important stakeholder on the issue of burnout and issues affecting physicians generally. And it's also an interest group on this issue, which means it has vested interest in promoting the welfare of its members. The American Medical Association can also serve as a potential partner, not just as a stakeholder, but working together with the Departments of Health and Human Services to ensure the implementation of this program.
So let's review the political landscape here in Pennsylvania as it relates to these issues. Healthcare continues to be a high-profile issue for Pennsylvania lawmakers and voters. Leading up to the 2018 midterm elections, it was the most highly searched issue in all but 4 PA counties. And although healthcare costs has been a hot-button topic recently, legislation related to healthcare quality is not without precedent. For example, looking back in the state history, the Pennsylvania Act of 2002, the Medical Care Availability and Reduction of Error Act, MCARE, established the Patient Safety Authority, also known as PSA, as an independent state agency tasked with identifying problems and recommending solutions that reduce and eliminate medical errors in hospitals, ambulatory surgical facilities, and other healthcare facilities. The PSA also administers the state's medical error reporting platform, known as PSRS, which is the Pennsylvania Patient Safety Reporting System. There are also several state-based organizations that have taken up physician burnout in their advocacy efforts, realizing the toll that it takes on healthcare quality and the system at large. The Pennsylvania Medical Society, PAMED, is a physician-led, member-driven organization representing all physicians and medical students throughout the state. PAMED website lists physician wellness as one of the many advocacy priorities, stating that the organization supports improving the practice environment for physicians to help alleviate unnecessary stress, and it's open to working with lawmakers to enact such initiatives. In addition, the foundation of PAMED administers the Physician Health Program, known as PHP, which provides mental health services to doctors within the state. So likewise, the Hospital and Health System Association of Pennsylvania, HAP, which is made up of member hospitals and health systems that provide health services, has been advocating for solutions to address contributors to physician burnout, including regulatory barriers and staff shortages. On the ground level, hospital and healthcare systems in Pennsylvania have been developing new programs and initiatives aimed at mitigating physician burnout and addressing medical error. Medical schools have also taken an interest in preventing burnout in medical students, and in recent years, the Accreditation Council of Graduate Medical Education, ACGME, has honed in on physician well-being and how that translates to increasing the quality of physician education and better patient care. It has also incorporated well-being into the residencies and fellowships core program requirements and holds the sponsoring institution accountable for prioritizing resident, fellow, and faculty well-being. To aid in this important goal, the HGME has created initiatives to commission graduate medical education community to create transformative projects that fight physician burnout. Despite these organizational efforts, however, burnout, stress, and mental health issues remain stigmatized issues for physicians at the individual level. Studies have shown that medical professionals are often reluctant to seek treatment due to the shame and employment concerns.
We see no one-size-fits-all solution to the complex issue of preventing physician burnout. However, our policy proposal is designed to encourage the development of many policies that would address various root causes at the hospital level. Our proposed policy is to incentivize acute care general hospitals enrolled in Pennsylvania's Medical Assistance Program's Physical Health Choices program to reduce burnout among their physicians. To accomplish this, we would use the Health Choices program's previously implemented Hospital Quality Incentive, or HQI program, as a framework. The HQI program, which was introduced by the PA Department of Human Services in 2015, was part of a larger effort by the state to move away from volume-driven Medicaid payments to a greater focus on creating healthcare value and population health. The HQI was designed to incentivize acute care general hospitals enrolled in the PA Medicaid Assistance Program's Physical Health Choices program to improve the quality of healthcare services they provide. It measured and rewarded hospitals for incremental improvement in reducing preventable admissions and achieving the 25th or 50th percentile benchmark of a statewide preventable event rate. Hospitals that met the objectives qualified for bonus payments from the state, funded by proceeds from Pennsylvania's statewide hospital assessment program. Incentives were paid out on a sliding scale, and hospitals could qualify for either or both incentives, as shown in Figure 1. Our proposal is to adapt the HQI framework as a model for incentivizing these hospitals to reduce physician burnout scores in their institutions. We would utilize the Maslow Burnout Inventory, or MBI, which is an assessment tool to measure burnout in individuals who work with people, such as human services professions, as a mechanism for establishing statewide benchmarks and for the purposes of tracking changes at each hospital year over year. The MBI Human Services Survey for medical personnel includes 3 scales. Emotional exhaustion, or EE, which measures feelings of being emotionally overextended and exhausted by one's work. Depersonalization, or DP, which measures an unfeeling and impersonal response toward patients. And personal accomplishment, or PA, which measures feelings of incompetence and successful achievement in one's work. For the purposes of this project, overall burnout score would be the sum of EE and DP, as has been done in previous studies. We hope to partner with the Hospital and Health System Association of Pennsylvania, or HAP, to administer this survey. The HQI framework would be adapted to create a new Maslow-based scale aligning with our program goals, as illustrated in Figure 2. Participating hospitals would then receive bonus payment based on improvement over their own baseline the previous year, as well as their percentile among all Pennsylvania hospitals. The Department of Health would also play a role in outreach to hospital executives to inform them of common causes of burnout and approaches they may take to effect change at the hospital level. The program would be funded through the Pennsylvania Quality Care Assessment Program, which has been reauthorized for July 1st, 2018 through June 30th, 2023, with an anticipated total assessment revenue of $930 million. We propose $25 million, $5 million in administrative costs, and $20 million in incentive payments to be utilized for the purposes of this program, which would run July 1st, 2020 through December 31st, 2022. Over this time, we hope to see a decrease in burnout scores in hospitals participating in this program, as well as a proportionate reduction in medical errors. Possible unintended consequences include that by building upon existing programmatic infrastructure that applies to a select group of hospitals, we will not be able to incentivize all hospitals, nor private practices. However, it is our hope that the results of this program will support implementing physician burnout as a quality measure for a larger scope of hospitals in the state, or eventually perhaps as a CMS reimbursement quality measure. In addition, implementing new focus for the HQI program is uncharted territory and may require additional capital investment than anticipated to account for staff, administration, data analysis, and report writing. Beginning on July 1st, 2020, the new physician burnout-focused Hospital Quality Incentive, or HQI program, will kick off, utilizing the following framework for implementation. The initiation phase will run July 1st, 2020 through December 31st, 2020, during which time the Department of Human Services, or DHS, will announce the new HQI program to hospitals in the Physical Health Choices program. The announcement will inspire action as well as stipulate the steps that must be taken by all hospitals to be eligible for incentive payment. In Q4, our program partner, the Hospital and Health System Association of Pennsylvania, or HAP, will survey all hospital physicians in the state with two goals. Firstly, the survey will establish a baseline Maslow burnout inventory, or MBI. Note, 30% of physicians must participate in the survey at each eligible hospital in order for the hospital to participate in the HQI program in the coming year. Secondly, the survey will ask questions about various aspects of physicians' working environment, the effect on feeling burnt out, and whether they feel they receive enough support from their employer. Data from this work environment questionnaire will be used in the evaluation of our program. The PA Department of Health's role will be to develop outreach and education materials about physician burnout to be shared with hospital executives across the state. The materials will provide education on causes of burnout and encourage policy changes that can be made to improve the working conditions of physicians. This step will also be repeated prior to kickoff of Working Phase 2. Working Phases 1 and 2 will run January 1st, 2021 through December 31st, 2021, and January 1st, 2022 through December 31st, 2022. During this time, hospitals will implement programs to reduce and or prevent physician burnout in their institution in order to earn incentive. In the fourth quarter, our program partner, HAP, will again survey all hospital physicians in the state in order to gather new MBI data for the new year and establish new benchmarks for the state. Again, 30% of physicians at each participating hospital must take the survey in order for the hospital to be eligible for incentive. And the survey will also gather new data through the work environment questionnaire. Analysis phases 1 and 2 will run January 2022 through March 2022 and January 2023 through March 2023. During this time, DHS will review, analyze, and calculate incentive payments by comparing year-over-year MBI results and using the system presented in previous slides to determine who has met the criteria for incentive. This physician burnout-focused HQI program will run for 2 years as it is funded by the PA Quality Care Assessment Program that has been reauthorized through July 2023. Hospitals will participate throughout calendar years 2021 and 2022. Payments will be processed annually in April 2022 and April 2023 to allow time for data analysis. The total amount of $10 million for state fiscal year 2021-2022 and $10 million for state fiscal year 2022-2023 will be paid to qualifying acute care hospitals through the Physical Health Choices plans to encompass the entire $20 million designated for the incentives for this initiative.
This section presents the evaluation plan for the 2-year hospital quality incentive program to reduce physician burnout. The policy or program goal is to reduce the rate of physician burnout by 30% in the first 12 months and 50% in the second year. Outcomes to be measured will include primary and secondary outcomes. The primary outcome is to reduce the rate of burnout among physicians in Pennsylvania hospitals. The secondary outcomes include to improve work environment factors that affect burnout, to decrease medical errors in participating hospitals, to increase the number of physicians that access the health quality incentive program, and to increase physician satisfaction with the program. The outcomes that are measured at the baseline will also be repeated to provide the data for comparative analysis. The data for this evaluation will be obtained through existing database of the Patient Safety Authority. The time frame for the evaluation. The evaluation will begin from the beginning of the program in July 1st, 2020, and continue to the end of the program in December 2023. So in 2020, we're going to get the baseline data using the Maslow burnout inventory and work environment questionnaire. In 2021 to 2022, these measures will be repeated at time periods to obtain data that can be compared. This will give us sufficient time for maturity of the program and outcomes. Measurement tools. The Maslach burnout inventory will be used to measure the baseline burnout levels in the fourth quarter of 2020. The adapted version of the work environment questionnaire will be used to measure workplace factors that affect physician burnout at baseline and also in the subsequent measures. So these measures will be repeated in the 12th month and in the 24th month to determine if any changes in the variables have happened. The baseline measure will be compared with outcomes that are measured in 2021 and 2022. The Department of Health will, in the first quarter of 2022, compare the 2020 and 2021 results from questions related to health system support. And the result of this will be used to make decisions about the need for program continuation and if there are areas for improvement. The Department of Human Services will review, analyze, and calculate incentive payments by comparing the 2020 and 2021 Maslach burnout inventory results. Finally, analysis tools. Quantitative method will be used to analyze the data. And this will include descriptive analysis using tables, percentages, and median or mean, depending on what is found more useful based on the data. And standard errors will also be calculated to help us describe the characteristics of key variables. Time series analysis will be used to analyze changes that have occurred over the period in the baseline to the 12 months to the 24th month period of the analysis. The time series statistics will use multiple regression and will be used to analyze the key program outcome variables related to burnout, work environment, and to measure any changes that have occurred within that period.
To conclude, it is evident that legislative support needs to be provided to tackle the ongoing battle of physician burnout. It is tragic that the physicians we entrust to heal the people in the community are the ones suffering and taking their own lives. As many as half of the physicians experience substantial symptoms of burnout that lead to depression, dissatisfaction with life, and more often than one might want to admit, attempting or committing suicide. In the fast pace of healthcare systems, medical professionals are tasked with long working hours, endless electronic medical record documentation, and pressure to meet quota and patient volume, with this resulting in the loss of passion for the profession and to lose sight of what's at the heart of medicine, the patients. The Physician Burnout Hospital Quality Incentive Program can help diminish physician burnout rates in acute care hospitals that are enrolled in Pennsylvania's medical assistant programs. To reiterate, the program can come to fruition with the adaptation of the MBI framework to establish statewide physician benchmarks, the assistance from the Department of Health to conduct outreach to hospital executives, and the funding and support from Physicians Hospital Assessment Program. So with that, Dr. Levine, we'd like to say thank you for your time.